This is a DBT Podcast. This is a DBT Podcast. I bring on experts that have been doing what they do for the last 30,000 hours. There's a 10,000 rule I'm trying to bring experts that really, have been in a field of medicine or another profession so that we can give you accurate information. Today I'm really, 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 really lucky. I have a close friend of mine who I've known since the University of Illinois, Dr. Dean Ferrera, also happens to be a very good looking guy. I mean, that's just coming from me. And he's taking care of thousands of patients. Obviously, I'm told that we need the heart to live. Is that correct, Dr. Ferrera?
Generally speaking, yeah, it's a good idea to have a pumping heart to live.
So, obviously 50 years ago, things were much different. I think, we couldn't do much to help people when they developed, heart attacks or, had issues with their heart. Is that right? Like, let's take 1975. I heard you guys were just prescribing cigarettes to calm your nerves if you hearts. And then, um, you know, uh, I think health insurance at that time was like a handshake and a prayer. Can you tell me a little more about how things have kind of evolved over the last 50 years?
Well, fortunately, it's before your and I time, but I think, the docs and the nurses were smoking cigarettes at that time in the hospital. But, obviously you picked a good time frame, or maybe not obviously. Right around that mark in the mid 70s is where we started to see angioplasty come about. And it was really in the dawn of the early 80s when Dr. Andreas Grunsig brought that to the forefront of medicine. And that changed the game and how we manage heart attack patients across the board. So yeah, it was a different world back then. And the progression went from interventional cardiology springboarding into angioplasty to then the use of IV thrombolytic drugs, which help break up clots that cause heart attack, and now procedural based cardiology. So just that continuum just developed, since that eighth decade and into the ninth decade, and then of the last century, that is. And then from there, we have now what's modern day routine practice.
I kind of want to start from the beginning because I feel like a lot of listeners will want to kind of get the basics, and it's actually a good review for me to just review the
Sure.
science. All human beings are built the same. We all have a heart. Is that correct?
Yes, sir.
All right. And obviously we can't live without a heart. What does the heart exactly do for us to keep us alive?
Yeah, I mean, so it's our lifeblood, right? It's the circulation. So the heart itself is the pump in the body, the pump that provides blood flow to all the major organs, including the brain, the thing that gives us consciousness, right? So we can't live without it. Our brain doesn't function without it, and so it's a central organ. And we intuitively know what a pulse is. We feel it. We understand that we have to have a pulse to live. But really, that's our circulation. That's what we're feeling when we feel a pulse. We're feeling that blood flow coursing throughout our body and getting to where the blood needs to go to nourish all the tissues.
And what about blood pressure? We all, every year I myself get my own blood pressure checked. My whole family gets their blood pressure. What does that mean? They give you that top number and the bottom number. I know the normal ranges as a hematologist, oncologist, but I want to get better understanding of, for everyone out there, like, what does that mean if your blood pressure is high or low or, whatever the case may be?
I mean, it is a common thing to have our blood pressure taken, right? So from a young age, going into a doctor's office somebody puts a cuff on us and takes our blood pressure. And yeah, of course, we know high blood pressure is a bad thing. I think we've learned those buzzwords over time, but folks don't know exactly what that means. And so I'll start by just saying the two basic numbers represent, the blood pressure, or the pressure within our blood vessels themselves, specifically in the arterial system, during both systole, that's the top number, and diastole. And so systole is the phase of the heart, as you know, Neil, where the heart is squeezing, it's compressing, and it's ejecting blood. And so that's when pressure is the highest in the bloodstream. And so we measure that top number. And then the heart relaxes, and that phase is called diastole. And so when we're in the state of diastole or heart rest, we still have to maintain blood pressure because we have to get blood throughout the body. And so there is, in that relaxation phase, a blood pressure we can measure, and that's the bottom number, right? So that's systole and diastole, or top and bottom.
I mean, I think people are learning more and more about their health, and they go into the doctor's office and they're having all these things done. And I think it really helps for you to explain like why they're having those done, right?
Sure.
So if their blood pressure is really high, that can be, tested by that cuff or an Apple Watch or whatever, what does that mean for that person, down the line? Like what risks do they have to their heart? Because obviously, as we discussed, heart disease is, our hearts failing is the number one way that humans die.
Right.
So, what does that mean over the long run? Are there like risks to damaging your heart, starting with blood pressure and other things?
Of course. I mean, heart disease, as you know, is the biggest pandemic threat to life. And when we see high blood pressure, that's the starting of a lot of bad things that can happen, right? That's the start. So, not everybody with high blood pressure, thank God, is going to go on to have problems, but it needs to be managed because lack of blood pressure modification and management can lead to those bad things like kidney failure, stroke, heart failure, heart attack. Even these little things that we don't recognize, like and it's not little at all to you and I, Neil, but like kidney failure. I mean, most folks don't know that if they have high blood pressure, it can lead to kidney dysfunction. They might know it can cause heart attack and they might know it can cause stroke, but there's a lot of combined, morbid conditions that come into play if we don't manage our blood pressure. And, we don't like to just go by one value. We like to see trends, right? So if a patient comes in with a one off high blood pressure, depending on where it is, we may or may not, take heed at that moment, but we would generally at least recommend that we follow that. So for our folks listening, right, if you've had some high blood pressure readings, that's the time to start, in my opinion, start recording that, writing it down, and then present that to your doctor. I'm not saying check it every 5 minutes, but I usually tell my patients if you're seeing some high blood pressures at home, write them down morning and afternoon, same day. Do that 3 days a week, and let's see where your trends are and let's intervene if we're seeing high blood pressures because we don't want those bad outcomes. We don't want the heart attack, the stroke, the kidney
So I think you
disease.
bring up a really good point that I am going to bring up over and over on the podcast because I hear it from patients all the time, and I think you hear it as well. Is that because you feel good, you must
Mm.
be good? And to me, the whole point of seeing someone like you or a lot of doctors many times is knowing that you and I aren't going to live forever, although you look like you might. Um, you know, Knowing that the human body is prone to get common conditions that when it comes to cancer we can screen for, when it comes to heart disease, there's things, modifications we can take. And just knowing that, the human life expectancy has gone up from 50 years ago was 72, 73. Now we're at 79, 80. And we have, as you've talked about, better interventions, but understanding that just because you can play basketball or golf and you feel great or whatever, that there can be these things that are lurking that you need to be, monitored for. Would you agree with that? Do you feel like a lot of people think because they feel good that nothing's going to happen to them? And like I personally, I do this myself. I'm not talking about, I mean, I have this, thing where I thought I was going to play in the NBA when I was 30, that even though I didn't even get picked for the high school team, someone would see me play and I'd make it to the NBA.
They'd recognize the
So
talent.
so exactly, and
Yeah.
I can still shoot three-pointers, but that's about it. My height, unfortunately, didn't agree with that dream. So, I want you to bring that up in general because I think it's gonna be a common theme, and I hope when people listen to this, because I see people all the time that are feeling great one week, and the next week, something's going on that we need to address. So you can go ahead, maybe and answer that question if you feel that you agree with that.
Yeah, I totally agree. I mean, I think, as a cancer doc, you know this well, we can't outrun our genes. And so, our genes come into play in both, oncologic conditions, obviously, in cancer, and then certainly in heart disease. And so when we think about heart disease as a global entity in our genes, and we tend to focus on, okay, mom, dad had a heart attack, but getting back to blood pressure, I mean, blood pressure is hereditary too. And, there was a point in time way back when, before you and I trained, right, that, hypertension or high blood pressure was called essential hypertension because it was thought that this is what we needed as we aged. We needed blood pressure to be higher to maintain normal function. And then studies have shown that that's just wrong, right? So that it is part of the aging process, yes, but it can come on earlier in life. And so, we've certainly seen, and I mean, I've certainly treated, younger patients in their 20s and 30s that have high blood pressure just for simple, management of it. But then I've also seen the bad outcomes, right? So I've seen the 20-year-olds and the 30-year-olds that have really unchecked high blood pressure and they're on dialysis. And I'm sure you've seen that too. And or, they have some thickened heart muscle and some signs of heart failure at a young age. So it's unfortunate, but it's not always the people you'd expect. And you can have folks that come in the office that just are not overweight and are exercise type people, but they just still have high blood pressure and it's hereditary. And I'll give you one quick example of that is I have a friend who's a cardiologist, and can't get into it, but obviously he's an experienced guy, and he was a team doctor for some for professional sports organizations, more than one, basketball, football, and he would mention that he's got some of these professional athletes that have high blood pressure, that have high cholesterol, and so these are the most fit athletes in our country, right? These are the people,
I
right?
mean, I'm learning from this conversation. Like, I think that's just a perfect, example of, you know, gosh, they're performing at such an elite level as
Right.
and yet they still have high blood pressure and high cholesterol. And, for whatever reason, the human body malfunctions. And so I think this idea that if you feel good, you know, that everything must be good, I think I want to really get that message out there.
Right. I
So
get it.
go ahead. I'm sorry I interrupted you. So you were
No, no,
talking
I mean, I interrupted you. I mean, I
about,
think your message is spot on. I mean, looking good, feeling good doesn't always mean that you are not without or not prone to some sort of illness or problem. You have to delve into the preventative care, right? You
right.
have to do the things you need to do, right?
So, we both look good and feel good, but I'm on a statin. Okay. So maybe we can talk about cholesterol. Is there something that I've been doing that maybe made my cholesterol? First of all, I would really like you to explain at a basic level, like, why do we check cholesterol and what's the point of taking these statin drugs? I read on the internet that they're going to cause me to have muscle aches and you know, all sorts of problems. There's a long list of side effects of these drugs, Dean, Dr. Ferrer. I'm a little scared about it, but, I went ahead and did it at my doctor's advice. So, maybe you could explain, why we check our cholesterol, when it should first be checked, and why it matters if we, do lifestyle modifications or start some medications.
Yeah, I think if I'm correct, and this goes back to our internal medicine days, Neil, I mean, the general recommendation was by age 25, most young adults should at least have had one lipid profile checked. And so, I see patients more of a selection bias, right? So they've already been screened and they've had high cholesterol checked by their primary care doctor, and then they refer them over to a cardiologist, for that or for high blood pressure management. So we're catching them, but I think the primaries out there, the primary care doctors that is, are doing their job and screening early. But in general, I mean, why is cholesterol bad? Well, we can go back to our hunter gatherer days where everybody had very very low cholesterol, below what we normally consider, well, at one point was considered unsafe to have it that low, rather, the numbers. But
And I want to go back to this life expectancy issue. Just to be
yeah.
clear, how long were hunter gatherers living? Because everyone thinks
Oh,
everything in the past is better. I think, in my opinion, this is the best time to live based on facts, based on life expectancy, technology. I know many people can be negative. On this podcast, we're going to focus a little bit on the positive because objectively, based on facts, people are living longer than they ever have. Is that true, or am I not being accurate?
totally. Totally. I mean, I think you in your opening statement, you nailed the life expectancy. But right. I mean, folks back in that day were dying in their 20s and 30s, right? It was hard to get out of that realm, if that. But what we have speculated is that their cholesterol levels were very, very low, in part because of their diet. And potentially, and you can find research on this, but potentially how they consumed meat products, et cetera. But what we know, I mean, especially in the States, the American diet, most patients are going to have cholesterol that's going to be up to that, low 100 range. And that is considered normal, right? We have set, for years, the upper limit of normal for cutoff of a high cholesterol of 200 or more, with particulate sizes of the LDL cholesterol and the HDL cholesterol, which are the subfractions of cholesterol management, of course. And we've set kind of normal values for those. But anytime we've ever really looked at lowering cholesterol, most patients do better. And so, to your point, what is cholesterol? Well, our bodies need cholesterol, right? It's a chemical made, in the body,
So it's a good
principally by the
chemical, not
liver.
one of those bad chemicals.
Not the bad stuff,
Okay.
but we need it. It helps us make steroids in our body or hormones. It helps us make, cell membranes. So these are, naturally occurring compounds.
So when they're too high, does it increase your chances? Of course, as I've discussed in medicine, and I want to make this other point and tell me if you disagree with me, everything is a risk and a benefit. Just because you have high cholesterol, just because I have high cholesterol, doesn't mean I'm going to have a heart attack in the next 6 months. I
Correct.
think if I left the cholesterol alone, my risks for having a heart attack would be higher over time. Is that basically correct?
Yeah, correct. I mean, it's not a one hit thing. It's more additive insult. So if it was high cholesterol plus diabetes plus high blood pressure, your risk of heart attack is going to be higher than if it's just high cholesterol alone. But high cholesterol is nothing, to dismiss. I mean, it should be managed, and as you said, there's meds for it, right?
So on my Facebook feed, there are companies telling me to do a wide panel of tests for myself, I think every week, um, for my heart and my health. Like, what do I know, that's why I like talking to docs that are kind of like, around our age, because I feel like, we know the stuff in the past, how it was, but we're also pretty good with technology. So we're absorbing a lot I just think, the amount of emails, texts, phone calls we do, we're just pretty quick at getting information and analyzing it. So, do you think, like, besides a lipid profile, is there, there's something called lipoprotein A and some other things. Like, do you think, well, like, tell me I mean, I have high cholesterol, I'm on a statin. What other tests should I get? Should I get the lipoprotein A, or, what other should I pay $5,000 a week to get the special lab tests, or like, what should people do?
I mean, I think lipoprotein A is a reasonable marker to check. The two you'll hear about are lipoprotein A and ApoB100, and they are, subfractions or subparticles of cholesterol that do increase heart attack risk. But do I check an LPA and an ApoB100 on every patient? The answer is no. I mean, I think a lot of our patients that are coming in.
Did you check your own? Did you check your own?
Actually, I have not. That's a
Okay,
good question.
curious.
That's a
Okay.
good question. But there's a reason for that. I mean, I don't have a high risk family history, and so LP little a patients or elevated LP little a patients are typically those that are going to have increased heart attack risk at a younger age, right? So some folks will have what we call a familial hyperlipidemia, where their cholesterol is markedly elevated just because of genetic pre-circumstance. But then on top of that, others are going to have a high LP little a, and that usually will show up, um, creating a high risk of heart attack at a younger age. So these are, I've had patients with high LP little a's that are in their 30s or early 40s that have had heart attack, right? So those are the ones where if I see that in a patient, and again, there's a little selection bias. So I'm seeing these patients after they've come in. I'll check it, and I check it so that they can inform their family. Now, if somebody comes in and is establishing care with me and I'm taking their family history and I ask, has anybody in your family had a heart attack? And I get the response, yeah, my dad had a heart attack at age 42 or 45, and my mother had a heart attack at 47, something in that, 40s range or even younger, then I'm going to check it, right? I'm going to check that LP little a on top of their, routine lipid profile, because even if their lipid profile looks pretty good and their LP little a looks high, we owe them some protection, I think, with statin drugs, and then later in time we're going to have drugs dedicated to LP little a lowering. We don't have them out yet, right? So overall, it's more about treating the whole cholesterol package than it is one specific marker. Um, but that's a reasonable one.
So, I take this drug, medication called a statin.
Mhm.
I, was obviously, as a physician who that's the first medication that I've taken regularly in my life, and was concerned about the side effects, including muscle aches and other things. Why would you encourage someone prescribed a statin to take it? Like, how much does it decrease their risk of, heart disease in the future? Is it well studied? Is it one of the things that's newer? Can you explain that a little bit?
Yeah, I mean it's well studied. Definitely decreases risk getting cholesterol down, and then even in subpopulations where patients are diabetic, etc., we know that there is a sustained benefit. So if somebody first presents, with a heart attack, in their even if their cholesterol profile looks good, we know that putting them on
Hmm.
a statin drug is going to reduce their risk of having a second heart attack. Same issue with stroke. If we see somebody meet them for the first time, unfortunately they suffered a stroke, even if their cholesterol looks good. And we hear this all the time. Well, my cholesterol's always look fine, doc, but why do we need the medications? And that's because they stabilize plaque and they decrease further risk. So that's been well, studied and shown. And then, on top of that, fortunately, I mean, the muscle aches and pains, these side effects, the profile is really on the lower end. I mean, I don't know. Did you get any side effects like body aches when you
I
started taking
haven't had
statin?
any, and one important thing that I think people probably don't ask enough to their doctors is if I stop the medicine, if I have a bad side effect and I stop the medicine, what's will that side effect go away? So when I'm giving a patient, drugs to treat their cancer, I do talk about the major side effects and what I can do if they experience that side effect, because I think it gives them a little more comfort to know that they're just not going to have something for the rest of their life.
Right.
So, with the statin drugs, my understanding, please correct me if I'm wrong, I'm not a cardiologist, so I have you on as an expert. Um, you know, if I got muscle aches, I could just stop the statin and those muscle aches would probably go away. Is that correct?
Yes, generally speaking, if you do get statin induced, body aches and pains, typically stopping the drug, it'll go away.
And that's I just think that's a true thing for everything in life. Like, yeah, but some people may take it, and yeah, there's like a 1 in a million chance that you do have muscle aches for the rest of your life, and we don't really know why. I do have patients that have like a 1 in a million side effect to a drug that I've never seen after 15 years of treating so many patients. So
Hmm.
I think everything there is a risk to everything, obviously. But, at least to me, when I looked at the long term profile of me taking the statin, I think it reduces, my risk of getting a heart attack, especially with my family history, which I do have a family history of heart disease. Okay, so before every patient I have would be on an aspirin immediately at a certain age. My understanding of this now is that there's more bleeding with aspirin than there is saving people from heart attacks. Companies advertise for aspirin all the time, but I think now not everyone needs to go on an aspirin. Is that correct?
Correct. So that's been shown to, as you said, increase risk of bleeding, right? So aspirin's a great drug, definitely needed in our heart patients, our vascular patients, but it's got to be in the right patient. So if somebody's had a heart attack, has had a stent, if somebody has a vascular issue, poor blood flow in the legs, or has proven atherosclerotic disease, which is the plaque buildup within the arteries, then yes, they should be on aspirin therapy. Or if they've had an event like a heart attack or a stroke,
Stroke.
they should be on aspirin therapy. But for the otherwise, I'm not going to use the term worried, but for I guess I am, the worried well, but the well folks that are trying to decrease the risk of heart attack long term, it's about managing the other risk factors. And even though aspirin has some preventative value, the trade-off is it can cause some stomach irritation, some bleeding, and those sorts of things. And so, from a population-based perspective, not indicated as it once was in the past. I think we were also using it for colon cancer protection at one point. What's the data on that looking
Oh,
like?
it's a great question. So yeah, I do actually put every colon cancer survivor on aspirin to prevent
Oh,
polyps, and there's some data with that. I also use vitamin D. I think brings up an important point that you and I aren't just following some book. We are using guidelines and updated data and our real world experience of doing this for 15 plus years. And I think all that together makes us experts. I don't know someone, and I think this brings up a good point that I think I'm a better doctor now than I was 10 years ago from the experience that I've gained. I don't think an AI or someone coming out of med school is going to be able to think the way we do because we've seen so much in combination with obviously going to med school for 4 years, doing 3 years of residency, doing it takes 10 years. So when people are looking on the internet, that's one of the points of this podcast, like
yeah.
realize that the information is coming from people that actually you and we're never going to be I'm not going to be hosting a talk show on Saturday night. Like my main job for the rest of my life is to be a hematologist oncologist, and I know you very well. And I think your main job is always going to be a cardiologist, for the rest of your life and take care of patients. And that's our
Right.
profession. That's what we do. That's our expertise. So my next question is a little more blunt. Like, so you're responsible, and thank you for going into this field, but for the organ that kills the most people. So why do hearts
Hmm.
fail? Why do people die from heart problems? Is it just blockages? Is it, you talked about pressure, but is it, pressure on the heart, electrical conduction? There's I think something called myopathy, like cardiomyopathy, where I think the heart gets strangled or whatever. So maybe you can explain, like, what are the different causes of the heart just malfunctioning, and why do you think it happens?
Great question. So, I mean, the number one risk with heart disease, generally speaking, is heart attack. And a heart attack, aka myocardial infarction, right? That is the condition where you have plaque buildup within the arteries of the heart because of risk factors like diabetes, high blood pressure, smoking, kidney disease, and high cholesterol. So the plaque builds up within the arteries of the heart, and we can get into why or not, but the point is it does. And once it does, it becomes vulnerable at some point. And as it becomes vulnerable, those little plaques inside the artery can tear. And just like you get a skin tear and it bleeds and you form a little bit of a scab there, same thing happens inside the artery. But the artery is a closed space, right? So now you create this little blockage in there and you lose blood flow to the critical artery of the heart. And
And
these are the court.
I'll comment about why that's important. I believe the blood carries oxygen and nutrients throughout the body. Is that correct?
You got it. You
And
got it. And
so
so,
when you're not getting the oxygen, tissue is going to die, basically. Is that tissue is the
correct.
issue, I guess, right? That's what I always learned in
Tissue is the
medical.
issue.
Yeah.
Yeah. So then you lose blood supply to the critical organ that the artery is supplying. And in this case, we're talking about the coronary arteries, or the arteries that sit on top of the heart like a crown. And so once they start to block up and you lose critical blood flow to the heart muscle, that heart muscle fails. And so as it fails, it can't do its normal business. So the heart can't squeeze as well. It also can't conduct electricity normally, like it typically does, to follow its own rhythm. And so you get the maleffects of pump failure and arrhythmias, right? Funny heart rhythms. And then all of that can surmount and lead to death, right? So that's why heart attack or emergent heart attacks are such a big issue. But to your point, I mean, there's other diseases of the heart. There could be heart failure that comes from other reasons. The heart muscle could be weak for other causes.
Yeah, I mean, I think the coolest thing when we think of electricity, I think every person, the buzzword is like electric cars. I feel like everyone thinks of electricity. They think of electric cars. Like, are we going to be plugging in? So, to me, it's amazing. I don't think many people know about the electrical conduction of the heart, that it actually generates, electricity in a sense. And if it goes haywire, I know there are specialists. If your heart gets a funny rhythm, like atrial fibrillation is probably, you correct me again if I'm wrong, but the most common, kind of failure of the heart. Can you describe this atrial fibrillation? Because I feel like everyone's heard of it now. Drug companies are putting commercials for it, and I think
Your Apple Watch is looking for it. Yeah,
yeah,
so there's
yeah,
all these. Yeah.
exactly, exactly. So maybe you
Yeah.
can explain that.
Sure. I mean, so atrial fibrillation, so the heart, the normal rhythm of the heart is something we call sinus rhythm. And that's where the top part of the heart beats in lockstep with the bottom part of the heart. And the electrical signal starts in the top of the heart, the atrium contracts, pushes blood down to the lower chamber of the heart, and then it's kind of a 1-2, 1-2. And the bottom part of the heart is then injecting blood throughout the body. But in AFib, what actually happens is the top part of the heart is not uh, continuing to beat in an organized fashion. And in essence, that means the top part of the heart just kind of quivers and it doesn't beat in lockstep. And so now you get a condition where the blood is not squeezed from the top part of the heart into the bottom part of the heart as it typically should be in a normal rhythm. Blood still flows, right? So blood still gets into that bottom chamber of the heart and gets ejected out to the rest of the body. But since the top chamber of the heart is not beating, it's literally fibrillating. And that's kind of where the term comes from. And so you have this chaotic, funny heart rhythm. You have fibrillation of the top chamber of the heart. As a result, you get some standstill in some of the areas of the heart that we call the left atrium or left atrial appendage. And that area can now be prone to forming clots. And so, one of the reasons why AFib is such a big deal is not only because people feel bad within it, but it also typically is a chaotic rhythm. the heart can lead or can develop failure from that because it's a fast, chaotic heart rhythm. The heart gets kind of fatigued from that, if you will, but also is losing a little bit of a normal pump. And then on top of that, since that top chamber of the heart isn't really moving, blood can pool there and strokes can happen because blood clots form.
Well,
Yeah.
you brought up a word that I think we have in common. I'm a hematologist, so once you said
Yeah.
clots, my brain started getting excited. So I want to explain because I think people hear the word clots. I want to define that better. There are clots in the venous system, like deep vein
Sure.
thrombosis, and then you mentioned clots in the atria. Can you describe the difference? Because like sometimes people will say, "Well, I have a clot in my heart," and you know technically it's still true. They're both blockages of blood flow. Is that correct?
Correct. Correct.
One's happening in the venous system, one's happening in the arterial system. I tell people when you have, and again, I'm not a cardiologist, when they have blockages in their arteries in the legs, it's like having a heart attack in their legs, basically, in the sense
Okay.
that they have arterial blockages. And the reason that they have those is the same risk factors: high cholesterol, high blood pressure, smoking, all those types of things. You can get blockages pretty much anywhere, not just your heart in the arteries. Is that right?
Yeah, so you can develop, blood clots in the arteries, outside of the heart, certainly in the arteries of the heart, arteries of the legs, arteries of the neck, brain, but then you can also get them in the venous channels that you were discussing, right? So you can
Yeah,
get
and
those
that's
clots.
yeah, and for us, we know that, like you were mentioning, when blood's just sitting there and not moving, that's when we can get blood clots. When you and I walk, there's one-way valves in our veins that are pushing blood up, and when it's sitting there, that's when we're just more prone to get a DVT or deep vein thrombosis. And if someone has, there are multiple risk factors that can lead you to have that, kind of like cardiac disease and everything in medicine. I feel like there's nothing that's 100%. Everything is a spectrum of risk.
Right?
So what's the oldest, healthiest heart you've ever seen?
Ah, 100-year-old patient or so. Yeah, you'd be
So
surprised.
I'm just curious. 100-year-old patient,
Yeah.
and they have no blockages. Their electrical conduction is normal. They're walking around with no symptoms of cardiovascular disease. I just want to see if this is possible.
Well, I'm not going to say they have no blockages because I've never personally done an angiogram on somebody who's aged 100, but I'm
I'm age
speaking of like
100.
you
You
get
are
it.
welcome to do an angiogram on me.
But yeah, I mean, when we're talking about a good healthy heart, but what I'm saying is at age 100, if I'm seeing on an echocardiogram that your heart is beating strongly and with good force and pretty good valve function, I mean, you beat this war, right? I mean, you won. You got to 100 and you didn't die of any kind of heart condition, so that means you're doing things right. But there's also patients that we've seen in their 90s that I have done angiograms on. I've done angiograms and angioplasties on patients in their 90s, and yeah, every once in a while you'll see somebody in their mid 90s that comes in with some sort of condition. They're very functional people. Listen, in my practice, it's not routine that you get an angiogram just because you have chest pain or something like that. But if somebody is of advanced age and they're really functional and they're taking care of themselves and they have this threat and there's some concerns about a blocked artery, it might lead to an angiogram. And yeah, every once in a while you're surprised. You just take a look and you find pretty darn good looking arteries at that age, right? So um, it happens.
So
That's
it
a
is
good thing.
possible to get to 90 and have this type of heart. I have a couple patients in their 90s, but obviously I'm not assessing their heart. The things obviously you mentioned, genes, I think, controlling all these risk factors probably give you the best chance of doing that. Now, obviously we can all see that you're in pretty good shape. So what are you doing for your heart health as a cardiologist that's seen 30, whatever it is, spent 30,000 hours treating patients? What are you doing personally that you think, you know what, I'm going to keep doing these things because I think down the line it's going to give me the best chance of not dying from heart disease?
I mean, I think a big one, beyond just exercise is diet, but and so I'll talk about myself, but then I'll personally just mention that, most of my patients when I'm interacting on this and we're discussing this exact thing, I tell them it's basically the rule of 30 minutes of moderate intensity exercise 5 days a week. I mean, that's what the American College of Cardiology, American Heart Association recommends. And that's pretty easy to find. You can see that on the myamericanheart.org website. You can find that on goredforwomen.org. Two great websites. That's the AHA's website for women and heart disease. And there's a lot of good learning there, but you'll see the typical recommended exercise patterns, and so that's there. And so I try to do the same thing. I might not always get in 35 days a week, but then I'll do longer exercise regimens that are it's a little bit more intense on other days. And everybody's got to find their pattern of attack in there. For you, I'm pretty sure it's basketball, right? You're still playing a lot of
No, I
basketball,
stopped. I was a little, out of the bunch of guys that I played with, 30, 40% of them had ACLs or they had some orthopedic injury, so it wasn't worth the risk anymore, and I realized that my NBA dream was had faded. It really
you
never
passed it.
began. It really you gotta play on the high school team for it to begin, but, you know, I can still shoot a basketball, but yeah, no,
We can't all be Muggsy Bogues,
I
like
now I just do some hit running and 5Ks with the kids and stuff like
yeah.
that. Try to get the family involved. I know like you do that as well. So you were mentioning personal things that you do that maybe people can take home that you think are helping with your heart health. And I want to touch on you said something about diet and it's very controversial now. I just feel like everything's controversial. Can we just talk about everything and not be mad at anybody? That's why the podcast is called Don't Be Triggered. So I was a vegan for 6 months. I'm not vegan anymore. Maybe you can talk about processed foods, things that people can think about for their diet and what you personally do. Because I also feel like we're all creatures of habit a little bit. We get into a habit and it's kind of hard to change, especially as we get older. So maybe you could speak to that a little bit.
I mean, there's lots you can do, right? So I think the crux of the American diet is that we can put ourselves in a position just to rely on easy, convenient food. Anything that's down the street when you're at work, you can run out and grab, fast food and satiate yourself and move on. But it's not necessarily the healthiest thing, and you certainly know that. I generally preach a Mediterranean style diet. It's what I tend to follow as well. So that's making sure that your saturated fat intake is on the lower end as best possible, trying to cut out a lot of the red meat. And I'd love your 2 cents on meat and cancer risk, but it's focusing on poultry, focusing on lean fish, and you can have some of these other pieces of meat if you are smart about it. I generally tell patients, it shouldn't be your staple, but if it's a pleasure food for you, you've got to live your life. Go ahead and do it, but try to buy a better cut of meat, and try not to get something high in saturated fat if you're a red meat eater. It's funny how, when you're counseling a patient after a heart attack, like that's their first question, can I have red meat? Because they find such pleasure in that food.
Even cancer.
Y- y-
Yeah. Yeah. Yeah.
Yeah, but then, and in terms of snacking, it's nuts and fresh fruit and vegetables and legumes, and I think this is how we get our best microbiome too, right? You
Mhm.
don't necessarily have to fortify with a lot of other resources, and some folks out there will say I'm wrong, but that's fine. I mean, I still think if you try to eat less processed foods and create snacks that are based in more of a diet that follows that pattern, I think you're eating a healthy lifestyle. Would you agree?
I would. I mean, when you say some folks, there's obviously people on all sorts of stuff, keto, paleo, or whatever.
Right.
So, what about alcohol? What do you think about alcohol? I mean, we're learning that alcohol is a cancer risk. I still drink, but and I've drank with you before. But
Yeah.
what do you think about alcohol in terms of heart risk? Is there good data behind that?
No, it's mixed. I mean, so some of the older data would suggest that a glass of red wine was okay, or up to 2 glasses for a man, 1 glass for a woman, almost daily. Does increase HDL cholesterol, lower some other bad cholesterol profile markers, and can be salutatory. But we don't know. There's other
What about
things
tequila?
involved. So I
Tequila,
go ahead.
no. Tequila doesn't increase your HDL.
Not that I'm a tequila. Well, it's all alcohol effect.
Oh,
I mean,
okay.
that's my choice too, but it's all alcohol effect.
All right. So we
But that's a common question, right? Like, hey, can I have a glass of wine? Can I have a drink? And my staple answer is this is a moving target in medicine. Be wary of it. Speak to your other doctors in case there's any concerns about cancer risk, etc. But from a heart perspective, if you're not a heavy drinker and you've had some sort of heart event and you don't have a weakened heart pumping function and you want to have that glass of wine, that's okay. Patients that have weakened heart pumping function, I generally will tell them to hold off as much as possible, because why add any fuel to the fire? Alcohol itself can cause, in heavy drinkers, it can cause a really life-threatening cardiomyopathy, which is weakened function, and that is, that's something we got to avoid.
Well, like you said, I think everyone. I feel like especially when I see new patients, everyone thinks in definitives, and I try to explain that everything's a spectrum of risk. Do I think that one glass of wine a week caused your malignancy? I don't. But certainly we know that certain things increase your risk. So to answer your question, yeah, I think the data is there to say quite frankly, alcohol is just not good for you. I mean, at the end of the day. But to your point, like a steak, like for me, if I'm with you, I'm like, hey, Dr. Ferrera, let's have a glass of tequila. Like, I don't think either of us are going to say no. And I enjoy it, and I don't feel bad about it afterwards. And that's another thing. I think one myth before we end here is that something you did and this is a psychological, I was a psychology major, something you did caused some health problem. That's just not the case. Sometimes it's in your genes. Sometimes you didn't do anything. It's just shit happens. Would you agree with that?
Totally agree. And, for me, when that question comes up, it's usually, repasado, please, and let's move on. I mean, I think your answer is spot on, right? It's not a one hit effect that causes us to have problems. It's things happen in life, and we owe it to ourselves just to be the best we can at modifying our risk. But even in those that modify their risk well for cancer and for heart disease, there's going to be those folks that still have an event, and it's going to happen. And that's where you and I come in and helping the management piece, right, beyond the prevention piece, and that's that other area of expertise that we have.
Well, listen, I just want to say thank you for doing what you do.
Yeah, you too.
This many years in, we're in the middle. I think we're approaching maybe near the end of our careers, and really appreciate you taking the time today. I do have a little gift for you that I'll get you at the hospital. And we didn't get to talk any sports today, but
I'm sure it's going to be a big Lions banner or something that you're giving me
well,
as a
no,
gift.
this golfer that just won the U.S. Open. He's only 5'8". He walked on in college, so you and I still got a chance next year.
Let's
There
go.
was a there was a dentist on the practice range hitting next to Scotty Scheffler, so he made
Things can
whatever.
happen.
Yeah, so you got a chance.
All right. I'm going to keep swinging, man. We'll
All
see.
right,
We'll
me
see.
too, me too.
All right,
All right,
buddy.
well, you
Good.
have a great rest of the day. Thank you
You too.
again.
Thank you. Thanks for having me.